Why don't we get started with our next series of lectures? I'd first like to, again, draw attention to our corporate sponsors, the Ogden Clinic, the National Kidney Foundation of Utah, and the Utah Academy of Family Physicians. Also like to mention that this lecture series has a sponsor. Dr. Stephen F. Johnson and Dean Johnson, DMD, as well as Val Johnson, and this is in memory of their father, Vern Johnson, and also the Joseph R. Watson, MD Memorial Fund. As Dr. Brown mentioned during the business meeting, that sponsorship has been a real big part of the ability that we've had to put on this meeting and pay for the expenses, and these organizations and sponsorship of various lectures has been very crucial part of that. So we're now honored to have our family medicine residents from McCady Hospital do their presentations, their annual presentations. And I know that there are some from past years that are here gloating in the lack of their own personal intensity, given that these guys are probably all excited. But anyway, just to begin, they've worked very hard on these projects, and I think that you'll find a fair number of them are taking advantage of our move to electronic medical record keeping and the ability to mine data. That is the main purpose for, I guess, having electronic medical records in the first place, that and communication. But as you'll see, a lot of the data mining that they've been able to do was allow them to center their project around local data that has pertinence not only to their clinic, but to the Ogden area in general. So with that said, I will turn it over to Dr. Ben Brennan, who will first come up and present his case, and they'll each introduce themselves, tell you a little bit about them, where they're going, and we'll get on from there.
Good morning, my name is Ben Brennan. I'm a third-year resident at McCady Hospital. I grew up in New Hampshire, came here to Utah for schooling, went to the University of Utah for medical school. I have a month and a half, 6 weeks left of residency, and I will be going to Visalia, California. Perfect. I have no disclosures to give out. Today I'm just going to initially talk about the determinants of patient satisfaction surveys and reimbursement, and then we'll look at some patient satisfaction data and then how that correlates with prescribing of opioids and antibiotics. So I'd like to open with a case presentation. 49-year-old female with a history of 30-pack years of smoking with COPD comes in with a chief complaint of back pain, chronic low back pain, on opioids. She's run out of opioids about a week ago. Should be noted that she has been seen in the ER a couple times in the last month for respiratory distress. Patient comes in for pain control. After looking at all of her labs, her imaging, there's nothing concerning. I then tell the patient that at this point, opioids would not be the best treatment for chronic low back pain, and that for her respiratory distress could be complicated by her opioid prescriptions. So I offer her a non-opioid pain medications, a physical therapy referral, and the patient becomes upset and leaves. So one of the questions is, should satisfaction change how I prescribe medications? I think that's a difficult question to answer. Hopefully by the end of this presentation, we'll have a better idea. So the impetus for this talk, when I was a first-year resident, I was talking to one of the attendings, and he had had difficulties with patients getting upset when they didn't receive antibiotics or opioid prescriptions, despite him explaining to them why they didn't need those. And as a young physician, I was concerned to what extent my medical decision-making would be influenced by non-medical things such as patient expectations, patient satisfaction, and reimbursement. So I wanted to look to see if there's a correlation between patient satisfaction scores, payment, and then prescribing of opioids and antibiotics. So why are patient satisfaction scores, why are those so important? CMS created HCAHPS scores. HCAHPS scores are an evaluation of a patient's recent hospitalization to incentivize physicians and hospitals to increase their HCAHPS scores. Sorry, these are all based on HCAHPS surveys, which evaluates a patient's recent hospitalization. To incentivize physicians, they've tied payment to this. So approximately 1.5% of payment is withheld from hospitals. This is equivalent to about $1.1 billion in withheld money. So this can be recouped through, in part, by patient satisfaction scores, or HCAHPS scores. These are publicly posted online. For McCady Hospital, the one that I work for, their overall HCAHPS score is about 79%, which is average for Utah. CMS has created an outpatient version of this survey called CG-CAHPS scores. CG-CAHPS scores are not required at this point for all physicians in the outpatient setting. However, by about 2017, they may be required for all and will likely have payment attached to this. So Intermountain, in an effort to be ahead of the game, has created their own patient satisfaction survey called a Patient Experience Survey, which they've recently renamed. This is a 26-question survey that evaluates a patient's recent encounter with a primary care physician or outpatient physician. Questions vary from how helpful the receptionist was, how easy it was to get an appointment with a physician. There are questions specifically on the patient-physician relationship, on nursing staff, how clean the building was, and such. So I took patient satisfaction data from 2013 from all outpatient clinics. This totaled to be about 22,000 surveys. We looked at this and compared this to prescribing of opioids and antibiotics. Initially, I looked at mean satisfaction scores. So when you look at all patients or the control, the mean satisfaction score is about 4.51. When you look at prescribing of opioids and antibiotics, you can see that the mean satisfaction score are all about the same, showing that prescribing of opioids and antibiotics do not change mean satisfaction scores. A recent study in, I think, March of this year from the ER shows similar data, that opioid prescribing does not change patient satisfaction scores. So another question is, does this change payment? To understand this, you have to understand the way Intermountain does payment. They have something called the Value Recognition Program. This is based on top box scores. A top box score, this is a sample question from the Patient Experience Survey. A top box score is based on what a patient states. You have 1 through 5, 1 being poor, 5 being excellent. The top box score is exactly that. It's the top box or the highest score a physician can receive, which happens to be a 5. Payment or reimbursement for patient experience surveys is based on that. For outpatient physicians, if you get a 50% or higher top box score, then you will get a bonus. In other words, if you have 50% or greater 5s, you will receive your reimbursement, or I should say bonus. For the ER and Instacare, that happens to be 40%. That difference is likely due to the patient-physician relationship. So I wanted to look at top box scores in terms of prescribing. When you look at this, the y-axis is the average percentage of top box scores. The x-axis is the different groups of patients. The first group, this is all patients. This is the control. The second group, these are patients who did not receive an opioid. These are patients who did not receive an antibiotic prescription. The last group, or the gray group, these are patients who received an antibiotic prescription. As you can see, the top box scores are all the same, suggesting that prescribing of antibiotics in general does not change patient satisfaction or top box scores, and thus will not change payment. So patients with an expectation for an antibiotic. We looked at patients who have respiratory infection, as defined with these. These are patients, we chose infections that are likely be viral, meaning that you likely would not need an antibiotic for these. So how does this change satisfaction? So again, we looked at top box scores of patients who received an antibiotic with with a respiratory infection and those who didn't. The first column are all patients, are control. The second column, this is patients with a respiratory infection who did not receive an antibiotic. As you can see, it's about a 3% difference in top box score. Then you look at patients who had an infection, a respiratory infection, who received an antibiotic. That's about the same as the control. Although there's a difference, this was not found to be statistically significant. Although there is a trend, those patients who might have an increased expectation for an antibiotic have decreased top box scores. So then, how would this affect patients who obtain an opioid? We looked at top box scores, or average top box scores for patients who received opioids. Looked at all patients again, this is the control. We looked at all patients who didn't receive an opioid, and then we looked at all patients who received an opioid despite the diagnosis they came in with. As you can see, there's an increase of about 4.5% in top box scores. This was found to be statistically significant and can play a role in payment. So again, we looked at expectation. Patients with a diagnosis of back pain will likely have a higher expectation for opioid prescriptions. So we looked at patients who had back pain as defined here. We looked at their top box scores. So again, the first column is our control. The second column is patients who have a diagnosis of back pain who did not receive an opioid. There's a decrease of 4% in their top box score. When you look at patients who had diagnosed with back pain who received an opioid, theirs is 4% greater than the control. An 8% difference with patients who had back pain who did and didn't receive an opioid, which was found to be statistically significant and suggests that payment can be, that opioid prescribing can change top box scores and play a role in your payment. So the real question is, will this affect my payment? So there are about 2.4% of patients who are diagnosed with back pain and received an opioid. So let's just say that I took all those patients and I said, you know what, I don't care what your symptoms are, I don't care what your scans are, I'm not going to give you an opioid. How would that change my top box score overall? There's an 8% difference between the patients who had a diagnosis of back pain and received or did not receive an opioid prescription. If you take the product of those two numbers, you have an overall decrease in your top box score of 0.19%. Meaning, in order for you not to get paid or get reimbursement as an Intermountain physician, your overall top box score would have to be 50.18%. For outpatient Intermountain physicians, their overall top box score on average is 61.7%, suggesting that this plays little effect in your payment. So back to our patient, our 49-year-old with COPD, chronic low back pain. Should her satisfaction change how I prescribe medications? You know what? I would have to say no. If this patient were surveyed, she would likely not give a 5. she would likely give something lower. However, the question is, what is most important? Is the goal to have 100% top box scores? I don't think so. The goal is to treat patients well and have them be part of the decision making, not to make all patients happy. Although that is a goal to have patients happy, it is not the ultimate. So in conclusion, top box scores can change with the prescribing of opioids in general. Patient expectations may play a role in top box scores for opioid and antibiotic prescribing. Top box scores have a potential to affect reimbursement. However, this is to a small extent, and patients should not worry about reimbursement due to top box scores. Acknowledgements, I'd like to thank Mary and Gardner, who did a lot of the statistics and data gathering. Linnea Baggett from corporate office helped me understand how payment is done, and then Norm Anderson.
You know, I just forgot to mention that we're going to take questions, but at the end of all 6 lectures, and we'll have the residents up here as a panel, and you can come up to the microphones and ask them individually based on their topics. So no questions in between. Thanks.
Oh, okay. I know. Can you all hear me okay? Yes? Okay. All right, I am Dan Flanagan. I'm a resident here at McKay, fixing to finish up. I'm from Houston initially. Whoa. Okay, I'll step away. I'm from Houston initially, went to medical school there. My wife has some family out here in the area, so that's what brought me here for residency. And ultimately, I'll actually be working both up in Cache Valley doing urgent care as well as with the hospitalist group here at McKay, doing, of course, inpatient stuff. So over the course of residency, one thing that I felt early on that was an important part of being a physician, whether that was inpatient, outpatient, or anywhere in between, is really understanding antibiotics, how they work, why we use them, when we don't use them, and what the problems are when we overuse them or underuse them. Let's see, I got going forward here. Okay, no disclosures. Objectives. The objectives really are going to be kind of discussing a little bit about some of the trends of antibiotic use, antibiotic resistance, and then at the end we'll talk briefly about some situations and how we can use objective information to determine when patients need an antibiotic. And again, the whole idea is to prevent the unnecessary use of antibiotics, and we'll talk about why that's important. So the information I have, I got this from our infection control department here at McKay-D, and all the data came from them except for national percentages, which we'll go into here in a minute. That stuff I got from up to date because I figured that was a pretty universal resource. So pharyngitis, is this me doing this? Oh, no, okay, good. So the major diagnoses that I want to talk about are ones that I see all the time, both in my resident clinic as well as in the urgent care: pharyngitis, sinusitis, bronchitis. Because these are cases where patients come in saying, oh my gosh, doc, I have bronchitis. I need a Z-Pack. Okay, do you need a Z-Pack? Actually, I need a double Z-Pack. I'm like, well, why do you need a double Z-Pack? Well, because that's how long it takes to go away. Yes, that's how long it takes to go away. So in adults, just to give some background on these different infections, pharyngitis, about 15 to 20% are bacterial. That means 80 to 85% are not. Things we need to look out for would be mono, maybe allergic. Children, it's about 30% are caused by actual strep. Okay, so still a significant number, and we still need to be looking for it. So pharyngitis, this is data straight from the urban north region of Intermountain. This is all the clinics that feed information into this region. So total number of cases, this was last year. We had about 6,800 cases, and then how many got antibiotics, how many didn't get antibiotics. It was about half. Sinusitis in adults, all comers, 0.5 to 2% are bacterial. That number is going to be a little skewed when we look at how many people got antibiotics, because I think patients probably don't always say, hey, I had sinusitis. So we're probably seeing a skewed number in the clinics. In children, maybe 5 to 7%. So total cases, almost 12,000 with antibiotics was, I don't know what percentage that is. 60, 70% got antibiotics, and those are people coming into the clinics. Bronchitis, mostly viral. Again, we have flu, we have parainfluenza, coronavirus, rhinovirus, RSV, human metapneumovirus. Bacterial causes include pertussis, maybe about 1%. Of course, we're seeing some outbreaks locally here now. We have chlamydia, we have mycoplasma. So we're talking up to maybe about 6 to 7% of bronchitis caused by bacteria. And we had about a 68% prescribing rate for bronchitis. So why do I care? So we'll talk a little about C. diff, the ESBLs. I have a slide about that. Those are the extended spectrum beta-lactamases. We have VRE, vancomycin-resistant enterococcus, and MRSA. MRSA is actually downtrending through the hospital lab, and I think that that's related possibly to increased awareness, proper contact precautions, and proper treatment. So C. diff rates, between 2011 and 2013, we've gone from about 240 to 345, so we've seen an increase. ESBL, so just a little background. These are members of the Enterobacteriaceae who encode beta-lactamases. Normally, they can inactivate penicillin, but not cephalosporins, but these extended spectrum guys can actually also inactivate the cephalosporins. It confers extra resistance, makes it more difficult to treat. And we've been seeing a lot more of these. So from 2009 to 2013, the cases have almost tripled. Vancomycin-resistant enterococcus, again, 13 to 25, so on the rise. And I have had many patients with VRE, pyelonephritis, bacteremia, sepsis, who we have no antibiotic. There's like an antibiotic that can treat it. So this is a very important problem to be aware of. Now, switching gears a little bit from some of the statistics, I want to get into a little more of the nitty-gritty into how we can go about deciding which patients do and don't need antibiotics. And this is information straight out of Intermountain. We look at local resistance patterns and take that and put it into what is called care process models. These care process models have been adapted to these best practice flashcards, which are, you can print them out, you can find them, just print it out, and you can stick them in your pocket if you wanted. But you can actually Google for them, and I'll show a slide at the end on exactly how to find them, but literally you just type in Intermountain flashcards. It's the first Google search box. You don't need any sort of username and password to get into it, which is kind of nice. So they're open, at least right now, to everybody. So let's talk about pharyngitis first. So there's one for peds, one for adults. Now, pharyngitis and strep throat, traditionally, we've looked at the Centaur criteria. There's the 4 out of 4, I don't know how to use the laser on here. Right here, 4 out of 4 sort of criteria. Well, what is the probability of having strep? So we can have fevers, no cough. We have the swollen lymphadenopathy, and then we can have the tonsillar exudates and swelling. Now, if you had 4 out of 4 criteria, traditionally we would say, okay, the pretest probability is high enough, you don't even need to do a test, you just treat based off of that. If you had 2 or 3, you should do a test and then treat based on the test. If you had 1 or less, you should just not even do the test and not treat because the likelihood of having strep is so low. Well, Intermountain's gone a step farther in that for adults on the right, wait, is that right? Yeah, sorry, adults on the right, I'm just making sure because I'm looking at the left here. On the right, that if we have 4 out of the 4, we should get a test, or rather a culture if our test was negative initially. Of course, if the test is positive, we can go ahead and treat. So rather than saying, well, yeah, we have a negative test, but they meet 4 out of the 4, we could still technically treat them. Well, we're not until we get a positive culture. So that's a little bit different. Pediatrics, of course, we're going to get the rapid test, positive or negative. If it's negative, we're still going to go on to do the culture. Whereas in adults, if they don't meet the 4 out of 4 criteria, you really don't have to, and you just end there. And again, we know that the ramifications of having strep throat in kids is a lot greater than that in adults. So we really want to know for sure if the kids have the strep or not so we can properly treat them. And so this is the first page of each of them, and they're double-sided. So the second page talks about the best way to treat them based on the current, like I said, resistance patterns here in the region. So in adults, of course, we can do Pen-V. It's very cheap, readily available. We can do amoxicillin. If you're allergic, of course, there's alternatives. Lack of improvement, of course, see people back. That kind of goes across the board. Pediatrics, we can do here the Pen-V. We can do even IM penicillin. If you can't do that or don't want to do that, you can do amoxicillin suspension. The thing with the amoxicillin, just to be aware of, a lot of times when we prescribe it, we do 45 mg per kg twice a day. Here it's just 50 once a day. So it's not the high dose as we would treat for otitis or whatnot. And then, of course, there's options for those who are allergic. Sinusitis. So here, the big thing that we need to do is sort of determine, well, how severe is this? Is it severe, persistent worsening? And we've all been taught, well, if it's going on for 10 days, if it's, you're having fevers, if you were getting better, then you got worse, purulent nasal discharge. These are just different things that we can use objectively to try and determine who would benefit from an antibiotic. And if we determine that they are low risk and that they're not really severe or persistent or worsening, that it could likely just be viral or even allergic. However, if we think that they meet these criteria, then we say, okay, well, we should maybe try antibiotics. Now, there's other things that we should consider doing. You could see here, saline rinses, pain control, no to decongestants, cough meds, antihistamines, mucolytics, nasal sprays. Pediatrics, similar idea. Again, we can do saline rinses and pain control, then trying to avoid some of these other medications. And just to be aware, the pediatric one is for ages 12 months and older. And then if we determine that they need treatment, we can, again, follow the algorithm. We can start out on severe high-dose antibiotics, amoxicillin. We can do persistent worsening, same with the kids. Okay. Again, I don't expect you to be able to read all this and remember everything. This is available online, so very easy to find. And I'll show you how we can do that. Bronchitis. So this is the real kicker. This is the one that I have the hardest time sometimes with patients. I've had 70-year-olds come in and yelling at me because I don't want to prescribe an antibiotic. I've had a kid who came in, wanted to be checked for strep after finishing that morning amoxicillin for a cough. And the kid was still coughing. I said to Mom, she's still coughing. She's like, oh, that's how it goes. Yes, that is how it goes. So anyways, the first thing we want to look for is, are we concerned about pneumonia? Yes, no. Do we need to do a chest x-ray? Okay, if the chest x-ray is negative, are we worried about asthma, rhinosinusitis, flu, pertussis, COPD? And so the purpose of this is really to kind of rule out other things that really do need to be treated. And if ultimately we get down to, no, there's nothing that needs an antibiotic based on these algorithms, then we say we need to treat it as a chest cold. There's not one of these for pediatrics. There's only one right now. So no antibiotics. We would provide handouts. There's a great one that Intermountain has that's a chest cold, just a viral URI handout. It's a 4-page sort of fold-out thing that's really good. Symptomatic relief. We could do Tylenol, decongestants, cough suppressants. And then, of course, there's not really the antibiotic section because it depends on what we find that needs antibiotics. Okay, so just to, again, reiterate, the way that we can get to these things, this is just a screenshot from my computer. This is me not logged into any Intermountain things. You put in Intermountain flashcards, you can get the best practice flashcards. It's purple because I've been there before. You click on it and it'll pull this page up. Again, no login required. And then you have the pediatrics, you have the adults. This is very dynamic. Between when I first put my presentation together and actually just reviewed it a couple weeks ago, they had increased the number of adult ones. So there's things more than just infections here. But they have, geez, you can see all the different things. So anyways, the idea is that we can follow some sort of objective pathway to determine who needs, who doesn't need antibiotics in order to help curb the spread of some of these resistant infections that I referred to. So as we know, the antibiotic resistance is on the rise. We're all seeing it. We're seeing it in our clinics. We're seeing it with more resistant urine infections, with all this. And working together, we can help curb the spread of the resistance by decreasing the amount of unnecessary antibiotics. And that's going to help not only our individual patients, but also our community as a whole. I just found this comic a couple years back and thought that was pretty goes along with this. So, okay. That's it. Thank you.
I'm Johnathan Gardner. I'm also one of the third years from McCady Hospital. I grew up in northern Utah as well as Wyoming, and then I went to medical school at The Ohio State University. OH. Perfect, thank you. And then after my stint here, I will be going to the sprawling metropolis of Weiser, Idaho. It's a population of 5,500 people, and just for a little bit of a comparison here, 20 towns of Weiser can fit in the football stadium at Ohio State. So, but it'll be great. You know, my town was 2,000 that I grew up in, so it's at least twice the size of what I grew up in, so it'll be great. I have no disclosures, but I am taking donations for my loan repayment if you'd like to donate. To start off with, we live in an extreme society. Everything from the X Games, which are a sporting event just dedicated to extreme sports. The Olympics, the motto is faster, higher, stronger. It's no longer the accepted norm just to be normal. You have to do more than the next person. And a lot of times it doesn't even make sense. It even goes into politics and into religion. There's a lot of extremes in our society. And it does not only just fit into the religion or the politics or sports. It also goes over into our healthcare as well. For example, obesity. That's definitely an extreme. According to the CDC in 2012, over a third of adults were obese. And as far as pediatrics, the number was about 17%. With that is associated a lot of other healthcare costs. The heaviest guy who ever weighed in was over 1,400 pounds. Definitely an extreme. Another end of the spectrum is plastic surgery. This guy on top, his name is Justin Jedica. He was featured on a TLC series called My Strange Addiction. He's admitted to paying over $158,000 on over 125 procedures to get his ideal body look that's embodied in the Ken Barbie doll. And other people, these other females here, they've also done a lot of procedures to get to look like these dolls that are the perfect body. Again, extreme. But these extremes, although these are very, very evident, the extremes in healthcare don't have to be like this. There's also some in our own homes, in our own lives, that are also extreme. For example, diets. There's a lot of fad diets out there, some healthy ones like the South Beach diet, to some ones that are not so healthy, like the breatharian diet, which actually focuses on the consumption of air to help you lose weight. Not the most helpful thing in the world. Now, with the goal of being healthy and of increasing fitness, there's been a lot of exercise programs that have come about. Here's a couple of them. So CrossFit, their motto, forging elite fitness. P90X, extreme home fitness. Insanity, it goes without saying, that seems to be a little extreme. Focus T50, T25, again, it's all these kind of extreme workouts to help you increase your fitness and to get you to have that extreme lifestyle. Now, although their intent is good, these programs don't come without inherent risks. All of them come with a warning on there to consult your physician before starting a new program. And the most common causes or most common risks from these programs are injury, be it overuse injuries, strains, sprains. I've seen plenty of Achilles tendon ruptures in the Instacare. And we're going to be talking about one of the risks that I'm closely involved with one of these. But to start off with, we're going to start with a case presentation. So there was a 30-year-old male runner. In the winter season, he decided to do some cross-training, and after some research, decided to do some P90X. So the first day is the chest and back workout, which is essentially a lot of push-ups and pull-ups in various different forms. After pushing through that workout and finishing it, he did okay. And the next morning, woke up, he was sore, but went to work, took a couple ibuprofens to try to get him throughout the day, got home that night and said, I'm still pretty sore. I'm not going to do my second day workout. And went to bed that night, woke up in the morning, in the morning was much more sore. Noticed that his arms were swelling, was having decreased range of motion. Went to work again, took some ibuprofen, some Tylenol, started to ice his arms because of the swelling and thought that would help with the pain. And then at the close of his work day, noticed that he had some muddy brown urine. And despite increasing his fluid intake over the day, he was only having about 20 mils of urine out. And so drove himself to the hospital, was seen in the emergency department, and he was admitted for exertional rhabdomyolysis after they found a CK level of about 70,000. And so that's what we're going to talk about is exertional or exercise-induced rhabdo. So this is a cartoon from the CrossFit literature. Rhabdo is very well known in CrossFit. They actually refer to him as Uncle Rhabdo. It's depicted as this clown he was unfit to begin with, and he's kind of done this too early workout type deal. He's now standing in a puddle of blood, hooked up to a dialysis machine. His guts are falling out. Despite their caricature, it's not really a laughing matter. This is a serious disease and something that we need to recognize early. So today we're going to be talking about the pathophysiology, risk factors, prevention, as well as some treatment for this. Just as a quick review, muscles, they start with the individual muscle fibers that are grouped together in bigger groups to form muscles, and then they're surrounded by a fascial layer into compartments as well. Each individual muscle cell is optimized to convert chemical energy over into mechanical energy. Not to cause PTSD or anything, but the Krebs cycle is the main kind of factory to produce ATP. In the muscle, however, where there's a lot of overturn of energy during a contraction, you also need a more readily available way to form ATP. And so in that case, the phosphocreatine cycle comes into play. Creatine is made primarily by the liver and the kidneys, and then stored in the muscle as phosphocreatine. And then, as we see here on this bottom chart, it allows to quickly replace ADP, phosphorylate it through creatine kinase to form ATP, which can then be used more quickly for contraction. Now, ATP is not only used just for contraction, as we know, it's also used for cell upkeep and other necessary cell functions. So in the case of rhabdo, what happens is you have, with exercise-induced rhabdo, is the demand for ATP outpaces, the demand for ATP from contraction outpaces the ability of the cell to produce ATP for the rest of the cell functions. And so ATP is diverted away from less necessary things like cell upkeep to keep contracting. And it's one of those fight and flight responses, things that happened over evolution. So when the bear is trying to chase you and eat you, you can still get away and you can worry about upkeep of your cells later on. But with that, so with rhabdo, you run out of the ATP to upkeep your cell, and you eventually cause cell lysis, and with that, leakage of the intracellular contents into the extracellular space. So that's high levels of potassium, myoglobin, and other proteins as well, and electrolytes, and those can cause downstream effects, be it renal problems, cardiac problems, other things as well. And also that changes the osmotic pressure of your tissue, and so you can also get compartment syndrome because of all the water influx into that compartment. And that can also impede healing. So how often does this happen? Does this really apply to us? Do we really need to worry about this? So in order to kind of get an idea of who this affects in our region and how much we need to worry about this, I looked over the cases that were admitted to McCady Hospital over a 2-year span. So from 2012 to 2013, there were a total of 459 cases of rhabdo admitted to the hospital. Of those, there were 149 cases of traumatic rhabdo, so that's associated with like car accidents and things such as that. And then there are 310 cases of non-traumatic rhabdo. Of those non-traumatic rhabdomyolysis cases, the biggest group was drug-related. There was only one case of a statin-induced rhabdo that was admitted to the hospital. All others were overdoses caused by either narcotics or benzodiazepines, and patient was down for an undisclosed amount of time, be it intentional or unintentional. And then the others were, the exertional came in third place at 10%. Looking at the activities that these people did, it ranged from P90X to CrossFit to firefighting, cycling. All of these people were healthy individuals, actually were athletes, and they tended to be doing something that they hadn't trained for previously, so some kind of cross-training. Now, don't think that this just affects the weekend warrior. This does affect professional athletes as well. Looking at the age distribution here, it's more common in about the 20s to the 40s, and that tends to be the age group where they want to get back in shape as well. But I think the oldest we had was a 65-year-old after a marathon. So risk factors, age 20 to 45, healthy, physically fit. Hydration status played a really big role, as well as the ambient temperature. And then we did have one case of a sickle cell trait, and we're at a higher elevation as well, and that can increase your risk. Melanie Ogden, she is a tennis player who got this when she was cross-training in her off-season. So again, it doesn't just affect the weekend warrior. University of Iowa had 13 of their football players hospitalized because of this. It can affect all of us. So what can we do to prevent this? Well, the most important thing is to counsel, to start slow and increase intensity and duration with time. So even those people who are physically fit, such as our 30-year-old runner, he was able to he's able to run fine, but he didn't do much upper body strengthening exercises. And so when he cross-trained, that's where he ran into the problem. And so otherwise, just making sure that they have good workout hydration and nutrition, and then adjust their exercise for the temperature. Mainstay of treatment is fluids. Give them a lot of IV fluids, or if they're treating it as an outpatient, make sure they drink. But aside from that, you need to, with the fluids, adjust the rate to the urine output to about 200 to 300 mils per hour after you do initial rate of 1 to 2 liters per hour of a bolus. But again, titrate it to a urine output. Make sure they have good pain control, and then if they have signs of compartment syndrome, they may need a fasciotomy. Luckily, none of our cases at McKay needed a fasciotomy. Monitor for electrolytes, hyperkalemia. If it gets severe, you may need to do dialysis, and peritoneal dialysis is usually not sufficient. They need to do hemodialysis. Hypocalcemia is common. You don't want to replace that unless you have a problem with controlling potassium. Hyperphosphatemia is a problem, and hyperuricemia also. You may need to start some allopurinol in all these patients. If they do get kidney injury because of the myoglobin, there's really no specific treatment indicated unless you have other problems. So volume overload, severe hyperkalemia, severe uricemia, or acidemia and uricemia. So, keep it on the back burner if you need to. Muscle biopsy, is this indicated? Some people say absolutely yes, and some people say no, you don't really need to. What I've found from the research is if it's a recurrent episode, so if you've had this once, okay, that you could be fine. But if you have this twice, you probably want to check it out why you're having it. A lot of mitochondrial defects, metabolic myopathies, they can cause rhabdo. And so if you're having it recurrent, or if it's happening at a young age as well, so like adolescent years, you may want to consider a muscle biopsy. The other thing, though, is there's concern for malignant hyperthermia. There's a high correlation between exercise-induced rhabdo and malignant hypothermia. And so the recommendation from the anesthesia group is that if you have exercise-induced rhabdo, you treat them as if they have malignant hyperthermia for surgery, unless they have a test to prove otherwise. And so in that case, if you want to really rule that out, there is a contraction test that you can do, but muscle biopsy is really the definitive way to diagnose that. So going back to our case study here, so our patient, he was hospitalized for 5 days, got a total of 27 liters of normal saline. His CK level came down nicely from 70,000 to about 11,000 by the time of discharge, and then down to normal. Total cost for hospitalization and outpatient follow-up for this patient, $13,000. So not cheap. So in summary, it can happen to any of us, be you unfit or fit. And when you're telling your patients what to do, make sure that they are starting slow and work up from there. So cost of P90X, $190. Cost of hospitalization, $13,000. Being able to exercise without getting rhabdo, priceless. I was that 30-year-old. I was the runner. It was no fun to get it. But there you go. Thank you.
Good morning. My name is Daniel Sperry, and I am one of the third-year residents at McCady as well. John Gardner let me say that, without HIPAA violating, that I was the one that took care of him, and I didn't get a cent out of that $13,000. So, and I want to correct Ben as well. We actually have 6 weeks, 2 days, 9 hours, and 12 minutes until we're done. So, I'm very excited to go on to urgent care. That's what I've planned to do, and I've accepted a position in the southern part of Salt Lake County. I'm originally from Salt Lake, grew up in Orem, went to medical school in upstate New York, Syracuse, New York. And as a third year, we choose an area of concentration for our extra clinics, if that's not obstetrics, and that actually can be one. So mine has been chosen sports medicine. And so we do an extra amount of sports clinics a month, and a complaint we often have is that young athletes or children will come in with a complaint of concussion. So I'm going to talk about today concussions. First, I have no financial disclosures. First, we'll talk about the diagnosis and treatment of concussions. Many of you probably attended Dr. Sharman's clinic and speech about it yesterday. We'll talk about some of the Utah laws that have been passed, so it's important to know as providers when we are in the state of Utah, and also some new guidelines from the American Academy of Pediatrics. And I'll talk about, so our clinic, we've been trying to make an algorithm to figure out how to make sure children that come in don't get lost through the cracks and get adequate concussion management. First, I'd like to start with a case. So a 16-year-old female came into sports clinic. I'd seen her not after the initial concussion, but she had had a concussion in October 2012. She had crashed on her ATV, had a momentary loss of consciousness, and started getting a headache a day later, but evidently had not had full adequate rest from her sports activities in school because 1 month later, she got hit by another player during a soccer match, and for days to weeks after that had fatigue, restless sleep, light and noise sensitivity, and was not doing well in school. And so the parents and the athlete tried to figure out what to do now, but I also want to talk about what we could have done to prevent this, so that's important to know and diagnose concussions early. Some facts about concussions: between 1.6 million and 3.8 million sports-related concussions occur in the U.S. each year. Another name for it is mild TBI, or traumatic brain injury. They used to be graded from 1 to 3, and depending on the severity of it, that was how we treated it, but the new guidelines say a concussion is a concussion, and we treat it as such, no matter how severe. Athletes often don't report their concussions because they want to play in the game and don't want to have time away from that. The concussions are more likely to occur in organized sports than in leisure sports, and up to 20% of football players get concussions each season, so that's kind of scary, and definitely not 20% report it. Sports-related concussions may be more common in girls than boys in similar sports that they play. But boys often participate in more high-risk sports such as boxing and football. And high school players, in American football specifically, are more likely to have concussions than college-age players, possibly because they're still developing, possibly because there's more high school players out there than there are college players. The pathophysiology of concussions, so that's either a direct force, so something hits the head, or there's indirect, where there's a coup contra coup type injury, where the brain is getting jostled inside the head. And that disrupts the axons and the neurofilaments, and that causes swelling, degeneration, transection of those actual neurons. And the inflammatory reaction that occurs causes free radicals to accumulate, and you get sodium leaking out of the cell and sodium and calcium going into the cell, and this is quite disruptive. Some of the more common sports for concussions, so girls hockey, girls soccer, American football, boys hockey, some of those are the most common for concussions. They did a study when I was looking through the literature that showed that heading of a soccer ball was not statistically significant in causing concussions, but there are anecdotal evidence, and that's how people say they got them, is from that, but there are other ways if players collide or other mechanisms. But other sports, girls basketball, wrestling, lacrosse, volleyball, and baseball can get concussions, pretty much any contact sport. So symptoms of it can be varied. Some of the more common ones are headaches, dizziness, imbalance, nausea, vomiting, fatigue, difficulty sleeping, blurry vision, light noise sensitivity. Often these symptoms come not after the initial hit, but in the days and weeks after. Hearing difficulties, numbness, seizures show a more severe type of injury. Difficulties with attention or concentration, depression, anxiety, agitation, aggression. And these can be quite debilitating for the student or for the athlete. And often the treatment is important to initiate first. Most of these will resolve on their own. We'll talk about how we can help facilitate that. So the technical diagnosis of a concussion is that you have an external force causing head injury with new onset of confusion, disorientation, change in consciousness, amnesia, neurologic dysfunction, or subjective symptoms that they report. They can have any or all of these. It's important to ask the athlete about these after they get hit and examine them. We'll talk about some of the exams that we can do. Red flags to know of, especially for athletic trainers on the field, to know when to send them to the ER or to their primary care physician, are a worsening headache. So a headache will still be there, but if it's getting a lot worse over the minutes to hours. Seizures, difficulty awakening them, repeated vomiting, so more than one episode, slurred speech, cannot recognize people or places, increasing confusion, weakness, numbness, other neurologic type complaints, unusual behavior change, or if they were out for more than 30 seconds. So we have these special tests that athletic trainers can do, and we as primary care physicians or specialists can do. For all tests, it's important to have a baseline if that's possible. And some clinics out there, some physical therapy locations will allow any athlete to come in and take a baseline test so that if they do get a concussion, that can be, the scores can be compared. There's something called the SAC sideline measure that trainers or coaches can do. So it's a standardized assessment that checks orientation, immediate memory, concentration, delayed recall. It's a quick neurologic test and checks for exertional maneuvers. It's quite easy to administer. There's other ones called the post-concussion symptom scale, so that just grades on the symptoms that they're having, such as headache or dizziness. And then there's the Westmead post-traumatic amnesia scale, asks questions such as name, place, month, year, town, age, date of birth, and time. So these are just all different things we can do, not just to have one. There's one that often the neuropsychologists will use, or the physical therapist, called the acute concussion evaluation. So it's a form that the athlete fills out part of it with their symptoms, and then the practitioner fills out the rest. It talks about the injury, how it happened, the symptoms and how severe they are, and risk factors that they may have already had, such as other concussions or prior diagnoses or neurologic problems. One of the ones that is really important for us and probably heard about is the SCAT. It used to be SCAT-2 over the last few years. Recently, SCAT-3 came out. So it talks about subjective symptoms. It takes into account the Glasgow Coma score, the SAC, as we talked about just a few minutes ago, and evaluation of balance and coordination with the BEST test. The SCAT-2 was done in 2008, and it was updated and revised in 2013. Some of the questions were worded a little differently, and it includes a neck examination, a modified balance examination, and some background health questions. So the old SCAT-2 was for younger athletes, but now the SCAT-3 is meant for 13 and older, and there is one called the Child SCAT-3 if an athlete is 12 or younger. And these are all available. I just Googled it and looked at these online, free for everyone. And there's a SCAT-2 app, so I looked on my iPhone, but there's not a SCAT-3 one yet, but it's expected to come out soon. But still, it's a good, even if you just use the SCAT-2, it's a good assessment of a athlete's status. There are computerized tests that we'll often have them do in the office. So they come in, it takes about 20, 30 minutes. The one that often you probably heard of is the impact test, and that's showing a picture of an athlete doing it. Where's the laser? There we go. And it talks about some memory questions, motor speed, reaction time, impulse control, and then it asks them if they've had any symptoms, which prints out on a page that we get. There's other ones called the Computerized Cognitive Assessment Tool, the Concussion Resolution Index, and the Automated Neuropsychological Assessment Metrics. If you just look, you can Google computerized concussion tests, and there's multiple ones out there if your clinic wants to have one. As we talked about before, there's the BEST test, which is a physical exam finding we can see where there's 6 20-second trials of balance on both firm ground and on foam. The prognosis of getting a concussion, if you've had 3 or more prior concussions, that is associated with a 3-fold risk of future concussion just by having them and a slower recovery. There's what's known out there as second impact syndrome. It's not well defined and it's not 100% for sure that that's going to happen, but there's possible permanent damage that can occur if you've not recovered from the prior concussion adequately. But there's definitely a post-traumatic sequelae you can get called a post-concussion syndrome. You can get prolonged headaches, vertigo, other symptoms if it's not adequately treated. So the Utah law in 2011, it was called the Protection of Athletes with Head Injuries Act, and it requires amateur sports organizations and schools, except for ski resorts for some reason, to adopt and enforce a concussion and head injury policy and get written approval of the policy by parents or legal guardians. And then when a head injury occurs, the child must be removed from play and may only return after written clearance from a qualified healthcare provider who has been educated in the management of concussions in the last 3 years, and going to Dr. Sharman's talk yesterday counts for that. In 2013, they strengthened the law in a quite scary way, I guess, for us. So instead of saying if the child is suspected of sustaining a concussion, it says if the organization or agent knows or should have known. So you have to have a crystal ball, I guess, or at least be very vigilant in knowing what is going on the field. The American Academy of Pediatrics recommended in 2013 that children should rest from school. It was known that they need to rest from their physical activities, but often they need one of these education plans. So going through a neuropsychologist is helpful. Getting these and coordinating with the school. There's under the American Disabilities Act, you can have help for them so they can not just miss school, but have things done at home to help them. So for physical exertion, it's recommended that they limit their activity and then do a return to play protocol, often starting with light exercise, then gradually going up until there's full contact, and making sure there's no symptoms at each point as you're moving up. For some of the school accommodations to help with brain rest, they recommend limiting homework, reading, loud noise, texting. I mean, we're inundated with technology and with stimuli around us, and even just simple things like that can cause the symptoms to get worse. I got this from one of our neuropsychologists, Dr. Bushman. He recommends kind of a similar stage thing where you go for a certain number of hours a day and times of the week to get back into the academic sphere. So the reason I chose this topic, we're working in our clinic about trying to catch those athletes who maybe don't have an athletic trainer, who don't have the same resources as some high schools do, And so we wanted to make our clinic aware of these other providers, such as neuropsychologists, that are out there in the community, and to be able to help get a referral system and a central location so we can have the testing required for a baseline and to compare. We're still kind of working out how it will work with logistics, whether there's going to be a global fee or flat rate, because different providers have different ways they can bill and things they can bill for, such as athletic trainers and physical therapists. So just kind of to show you a general, the one we're making is a little more complicated, but you diagnose the concussion. If there's any red flags, then they need to be seen immediately. Otherwise, you obtain the history, possibly compare to a baseline, and do some of these basic tests, at least the probably impact test, the SCAT3, and the best test. And if they have symptoms, then they need to wait until the symptoms are gone to really make sure they can go on in the treatment algorithm. But once the symptoms are gone, we make sure to repeat the testing until they pass those tests. If they pass, then they can go to the graded return to play, cleared by either an athletic trainer or a MD or DO. If the symptoms don't resolve after a month, we often will refer. So this actual patient, the 16-year-old, was referred to a neuropsychologist, had some slight improvement, but could we have prevented some long-lasting symptoms if she had rested early? For the more complicated cases, we can refer to neuropsychologists, visual therapy, speech therapy, vestibular rehabs, neurologists, depending on what the symptoms are. It's just important to be aware of it and diagnose it early and treat it early. Thank you.
Is this, am I good? Good. All right, well, I'm Natalie Trent, another one of the third-year residents. Originally from Oklahoma, I went to Oklahoma State for undergrad and medical school. And in 6 weeks and a few days and hours, we'll be transitioning to Central Oregon, where I'll join a rural practice just outside of Bend. And I'll be doing inpatient, outpatient, nursing home, and hospice care. And today I'm going to talk a little bit about hospice, which is my area of concentration for this year. Kind of reviewing what you may not know about hospice. My conflict of interest statement, I'm not currently employed by any hospice organizations, but I've had educational interest in these companies, Intermountain, CNS, Birch Creek, and Applegate. And I would like to dedicate this presentation to the memory of Dr. Namir Kader, who taught me most of what I know. So the reason for this talk is to kind of dispel common misconceptions about hospice. So these are things that I commonly hear about hospice. From providers, hospice is something that happens when I've failed, or it's a death sentence for the patient, or we consider it when the patient's ready to die, or it's a waste of our resources. My patient doesn't need this. From patients, you often hear, well, I'll do that when I can't walk or talk, when I'm really bedbound and at the end. Or if I do that, it's going to speed up my death and I'm not ready to die. And then also just concerned that I don't want to do hospice. I want to see my doctor, so I don't want to transition to different care. And I'm going to discuss these things through this method here. What is hospice? What hospice is not? Who's eligible? And there are specific diagnostic criteria. What the benefits are, and how much does it actually cost? So I'm going to start with the patient scenario. This is a patient I was called to admit from the ER. 76-year-old man who was being admitted for C. diff with sepsis. I evaluated him in the ER, and he was quite dyspneic with conversation and really somnolent, so he asked me if I would call his wife. He says, my wife knows everything, call her. They lived in a rural Utah town about 3 hours away, so I got her on the phone late that evening, and she very easily relayed everything that had happened. She was definitely on the ball, knew what was going on with this guy, very capable of taking care of him, and obviously had been the primary caregiver. She then starts telling me about his medical history and kind of how he was doing at baseline. She said normally he suffers from class 4 heart failure, so he has dyspnea at rest. He's pretty bed or chair bound. And over the last few months, his appetite had declined. He had started losing weight even prior to the onset of his diarrhea. Due to his poor health, his wife had actually quit her job 6 months prior to care for him full time. So, little quiz for everyone. Who thinks this patient qualifies for hospice? Or who wants to talk to him about hospice today while he's coming in for C. diff and sepsis? Show of hands. So a lot of people would think palliative with this guy. It's a sick guy who's coming in and he looks really bad on exam. And I think the more important question is why or why not? What would hospice give him, and does he qualify? So I start talking to this patient, to his wife, and I start telling her about the hospice benefit. And, is this something that you do need help with? And he was needing quite a bit of help with his ADLs, needing supplies, would really benefit from a hospital bed or maybe a bedside commode, and kind of explain that hospice may be a way to give this patient better care, relieve some of that caregiver burden, and keep him maybe out of the hospital in the future, have someone come in the home and see him. They live in a really remote area, so it may be really beneficial. I then start to talk to her about caregiver burnout and how a lot of caregivers put so much effort into caring for their loved ones that they stop caring about themselves. And then they start to resent their loved ones. And this can lead to a lot of guilt after they die, which is really not good. And if we can avoid it, we should try to. When I mentioned that, she started to cry. She said, I've been so overwhelmed. It's not going well. And I can tell I'm going to be really guilty, and I know he's going to die. She said, thank you. Thank you so much for pointing this out to me, because I really need some help. And I think a lot of people think if they tell a patient, hey, you're dying and you need hospice, that they won't appreciate it, but she was very appreciative. And she said, please, can you have them come out to our house and evaluate and see if we would qualify? So the patient was admitted to the hospital for C. diff with sepsis. He completed a 5-day course, and then at discharge, he was sent home with a hospice consult to evaluate for his heart failure. I want to make a point that he didn't qualify for hospice for his C. diff or his sepsis, but he did qualify for his heart failure. A lot of people in the hospital came up to me and said, oh, he's going to hospice, can we send him home today? I said, no, he's septic, let's get him better, and then we'll send him home for his heart failure. So what is hospice? Hospice is quality, compassionate care for people facing a life-limiting illness. They need to have a life expectancy of 6 months or less, and for a lot of people, it's a change in hope. So especially if you're battling a disease like cancer, instead of hoping for that cure, you're hoping for just a comfortable death. It's a team-oriented approach, and at its core, it's the belief that each of us has the right to die pain-free, with dignity, with the support of family and friends. What it is not is giving up. This patient, for example, didn't want to die any faster. His wife wasn't wanting to say goodbye. Yes, please put him out of his misery. She was wanting to keep him at home and continue to take care of him, but the fact is he's dying, and she knows that, and he qualifies for this benefit to have some support during this time. Hospice is not a form of euthanasia or physician-assisted suicide. It's not for people who are just refusing treatment depending on where they are, like what their diagnosis is and what stage they're in. And it's not for people who are on active treatment of a disease. So now I'm going to talk about the different hospice-eligible diagnoses. And the reason why I really like thinking about these is, as physicians, we're notoriously horrible at predicting life expectancy. So when you're looking at your patients, who knows when they have 6 months to live? So I like these criteria because you can look at them and, Medicare's pretty much dictated this and put them forward, but these are the criteria saying your patient's probably actively dying and you should think hospice. They may qualify for this benefit. So as I go through these, think about patients that you have, or maybe even family members or friends. And if they meet these criteria, it may be time to get them the help that they deserve and that their family is really needing. I also want to point out at the bottom, debility is no longer accepted as a primary diagnosis for hospice, and after October 1st of this year, any claims with that as the primary diagnosis will be denied. As I go through, there are going to be a lot of similarities with these diagnostic criteria. So the big take-home points are these. You don't have to memorize every criteria, and you can always just ask for a hospice consult if you're not sure. But if you're seeing a lot of these signs in your patients, maybe it's time to think hospice. So loss of ability to care for self, speak, or ambulate, low weight or continued weight loss, or recurrent aspiration or dysphagia. So the first one, cancer. First of all, they have to have a documented diagnosis of cancer that should be widespread, not just a breast cancer in situ that's very curable, but something progressive that they may die from. Beyond that, a palliative performance scale of 70% or less, and I'll click to the next slide real quick to show you what the PPS score, palliative performance scale, is. This is a hospice-only scale, not something you need to memorize, but just to give you an idea, 70% is right where they have some reduced ambulation and not quite doing normal jobs, but still taking care of themselves completely and have normal to maybe slightly reduced intake. So not really that bad, but just a slight reduction in their activity. In addition to that, they need to not be on active treatment, so either refusing further curative treatment or not eligible to, or any signs of really advanced disease, hypercalcemia, cachexia, recurrence. For heart disease, they do need to be stage or class 4. They don't have to have all of these, but these are supportive. So they should be dyspneic at rest, pretty end stage. An EF of 20 or less is helpful. Unintentional weight loss or gain, because that could be fluid, or persistent symptoms despite optimal medications, and maybe inability to wean off pressors. For dementia, there's a separate scale, and dementia is, unfortunately, as a lot of us know, is not something that it's very easy to die from. You sort of linger on for years and years. So the end-stage criteria are pretty severe, and I'll switch real quick to the FAST scale, which is used for hospice qualification for dementia. And they need to be a 7A, which is, if you can read it here, where their speech is limited to about half a dozen intelligible words. Beyond that, it's loss of ambulation, and 7E is loss of ability to smile, which I think is the saddest one. And then any other supportive things that go along with dementia. So unable to take care of yourself, incontinence, any inability to speak or communicate, and then recurrent infection. For HIV or AIDS, you pretty much qualify if you have a low CD4 count and you're not seeking antiretroviral therapy. So pretty much low CD4 count is the main thing. Liver disease looks a lot like heart disease. You see the same palliative performance scale of just slight reduction in normal job and function, a low BMI, weight loss or gain, and then loss of synthetic function of the liver, any signs of advanced liver disease. For neurologic disease, and this really refers to like ALS and Parkinson's, this is pretty much based on, you can see either breathing or eating. So if they've lost ventilatory capacity and they're not wanting invasive ventilation, or if they're having nutritional deficiency or aspirating. Pulmonary disease, you'll see a lot of these are starting to look the same. Can't do normal jobs, weight loss, recurrent hospitalization, getting sick more, right heart failure, not responding to therapy. Kidneys, same stuff. Loss of normal jobs, low weight, continued weight loss, or pretty much any criteria for dialysis and not seeking dialysis or discontinuing it. For a stroke or coma, this is another one that has to be pretty end stage because a lot of people can't walk after a stroke or coma, and that doesn't necessarily mean you're going to die from that. So the palliative performance scale is much lower at 40% or less, which means mainly bedbound and requiring quite a bit of assistance. Other things are like the other neurologic ones, so inability to breathe well or eat. Those are the main things, or frequent infections or hospitalizations. So I'm gonna go through a couple more patient scenarios to kind of quiz you. So this is a 91-year-old male with no medical problems, pretty healthy, living alone, who came into the emergency department for decreased ADLs. He had a low weight, BMI less than 22, but no recent weight loss. He was able to speak fine, normal mental status, and tells you, you know, I've lived a good life. I don't really want a lot of aggressive care at this point. I just want comfort care. So who thinks this man qualifies for hospice? Who wants to put him on hospice? Show of hands. A few. So he got a referral for hospice, and he showed up in one of the hospices I was working with for a consultation, and they ultimately decided that he didn't qualify because he doesn't have any organs failing, he would just have debility. So with the old guidelines, he may have qualified, but currently he does not. So the next, maybe better question, would he benefit from hospice? And probably he wouldn't. This guy can't take care of himself. So if he were to stay at home, he would need full-time assistance, someone to be there in the morning and at night for all the meals and for bathing. Hospice can be there in the home for about an hour or two every single day, and they can give you some more support on other days, but they can't be there all day. So this guy really needs a full-time caregiver or a nursing home, which is what happened. He got referred to a skilled nursing facility. Last case, 68-year-old female with metastatic breast cancer and severe pain secondary to spinal mets. She's completed chemotherapy. She may still be eligible for palliative treatment, but there's no more curative treatment available for her. She's continuing to lose weight, and she has decreased ability to perform tasks, but she's still able to care for herself. She can still drive. She's still doing her shopping, all of that. Who thinks she qualifies for hospice? Great, a lot more. So she definitely does. She meets all the criteria. But then the other follow-up question, does she benefit from hospice? And that's really dependent on the patient. If she's having a lot of difficulty with pain control and having a lot of spiritual needs or social needs, then yeah, she'd probably benefit a lot by having someone come in and help her out. But if she's really independent and pain's not a huge issue, or if she wants to continue aggressive palliative treatment, you can get palliative treatment with chemotherapy or with hospice, but the hospice company has to pay for it, and those resources are really limited. So the chance of her getting continued courses of radiation or chemo for palliation are very small with hospice. So it may be to her detriment. So you have to kind of see where the patient's at, but she definitely would qualify. So the two main reasons to offer hospice, obviously the big one that I've been talking about, is your patients and their families desire and deserve a supported death process, but also it saves money. So on the first point, these are the services that are covered by hospice. You can see you get physicians, nurses, home health, spiritual support, social work, equipment, medication, supplies, volunteers, therapy, and bereavement counseling. And you can get this to 12 months after the patient's death. So even if we get a patient on an hour before they die, now their family can have free counseling to be supported by that, which can be beneficial for some of our patients' families. When we talk about hospice and payers, we're really talking about Medicare because Medicare makes up 80% of hospice patients, and that's just by nature of most of these people being older and qualifying for Medicare. There are other insurances that provide it, and there are certainly people who are not on Medicare that need it, but for the most part, we're talking about Medicare. The Medicare hospice benefit was established in 1983, and care can be provided wherever the patient lives at their home, SNF, assisted living, or group residence. Medicare covers everything that's included with hospice at 100% without copay, which is a huge benefit. And it also will continue to pay for your chronic needs. So for example, if you're on hospice for cancer, but you like seeing your doctor for your COPD, you can still do that, and they can still bill like normal. They just add a code modifier that signals Medicare, I know this patient's on hospice for cancer, I'm not billing for a cancer diagnosis, I'm treating their COPD. So you can still do that too. What they definitely will not cover is any treatment intended to cure your illness, any curative chemoradiation, or antibiotics, though a lot of times they'll do cheap antibiotics if they're for symptomatic reasons, and any palliative treatment not set up by the hospice team. So like I was saying with the palliative chemoradiation, if your hospice company goes to a radiation oncologist and says, we'll give you this much money for 5 radiation treatments, they can work that out, and that's fine. But you cannot go around the hospice company for that because Medicare will not pay 2 people for the same diagnosis. And then they do not cover room and board. So you have to either be in your home or find another way to pay for your skilled nursing facility or whatever the case may be. How much does it cost? Well, Medicare pays around $150 per person per day for hospice, and this comprises 2% of all Medicare expenditure. Since the 80s, Medicare has seen huge cost savings with hospice care. In fact, in 2007, Duke did a study comparing hospice patients with patients who were not on hospice but had similar diagnoses, and they were saving a little over $2,000 a person. In 2013, there was another study that showed that those savings are increasing, and we're saving up to $6,000 per person on hospice with Medicare. And that's for especially those patients that are on for that golden window between 15 and 30 days. That's where you see the most saving. The average length of stay is 69 days. You can see from this chart, most patients are on hospice for 30 days or less. That's the yellow and purple areas. Very few patients are on for more than 6 months when you look at the big picture, but certainly it happens, and that's okay, because if you don't die in 6 months, you don't get kicked off. As long as you're continuing to decline and actively dying, you're supported through this benefit. So the take-home points, hospice is a benefit for patients at the end of their life. They must be terminally ill and not seeking any curative treatment. There are specific diagnostic criteria that help us determine when they're kind of in those stages. And overall, this is a huge cost savings for our system and for the patient. If they're on Medicare, it's completely free to them. Thank you.
Good morning. I'm Cassie Whittier, and I'm the last of the residents to speak today. I actually grew up here in Ogden, so it's been a privilege to be involved in this for the first time. Went to Weber State University and then to University of Utah for medical school before coming back here to my hometown to do my residency. And I will be headed out to Tanner Clinic this summer in August to practice, so I'm excited about that. So today we're going to talk a little bit about weight loss medications. And this talk kind of came from some of my experiences as a resident with some attendings who are very familiar with these medications and others who try to not prescribe them or absolutely will not prescribe them. And I began to kind of question where that difference lies, whether it's the age of the prescriber and some of the experiences with issues with these drugs in the past. And so some of the data that came out of this is where this talk came from. So I have nothing to disclose, no financial disclosures. The outline we'll start with a little bit of obesity trends and medication history, controversy regarding these medications, the data behind treatment, local statistics, and then go through some solutions, some potential solutions for improvement in our treatment of obesity. So it's no secret that obesity is a problem in the United States. We all know that. We all deal with a lot of the comorbidities that come along with that every day. But the surprising thing that came along with this, looking at this data, was that a third of patients that have obesity are only a third of those are actually diagnosed with obesity or receive some sort of weight loss treatment advice during their visits with their primary care or other providers. And we know that there is benefit to weight loss, but it's down to the percentages of 5 to 10% down below their baseline where we actually see some of the improvements in the cardiometabolic outcomes. This map comes from CDC's website in 2012, and some of the stats were quoted a little bit earlier. But this is the prevalence of obesity in the United States, obviously. And you can see, sadly, that the 15 to 20% range is nowhere to be seen in the United States. But Utah does fall within the second to lowest tier, so that is good for us. The more interesting thing about this is that this is only self-reported obesity, so they take this off of surveillance data. So potentially the numbers could be even higher if most of our patients are not even receiving an actual diagnosis. Then maybe there are some of these that aren't even being picked up. So there's a very troubled history regarding these medications, and I obviously wasn't practicing in the 1990s and didn't experience this, but I heard about it when I was younger. And a lot of this comes from the controversy regarding it comes from the fen-phen crisis that developed. And this is the cover of Time magazine from 1996, and it's talking about redox, which is actually the dextroisomer of fenfluramine. It's dexfenfluramine, which is the other component of fen-phen besides phentermine. And even at that point, looking at the bottom here, they asked, but is it too good to be true? And it was the next year after this, in 1997, where it was pulled off of the market because of concerns for pulmonary hypertension and valvular regurgitation. A lot of lawsuits ensued after that. A lot of money was given to patients and their patients' families. Some of these led to even deaths. And we kind of swing back and forth, problems, a new medication comes out, then we find side effects and it gets taken off the market or people stop using it. But more recently, we're going to talk a little bit about the phentermine Topamax combo. And this is Dr. Oz talking about this, which my mother, unfortunately, listens to Dr. Oz quite a bit and follows his advice quite a bit. And so this is the new silver bullet. And there's a lot of other things that I found kind of searching for this where they're concerned about this, that maybe we're repeating history here. So additional concerns regarding the medication, especially phentermine, is that initially patients might have some weight loss, but then the weight loss eventually slows and then plateaus, and even with increasing the dosage of the medication, which increases the side effects, they may not actually lose any further weight. Patients often regain the weight that they lost while they were on treatment, and by the end of the treatment period after they're taken off of it, they're back to where they started with having been on the medication and the side effects that come from that. And many people who are treated with weight loss medications have a very unrealistic expectation of what's going to happen with the medications. They feel like they're going to go from a BMI over 100 to the Barbie dolls that we saw earlier. And that's very unrealistic, and it's important to make sure the patients understand what potentially could happen with these medications. So they actually looked at a study of women that were undergoing treatment for weight loss with these medications, and they had them identify their goal weight, their dream weight, happy weight, acceptable weight, and disappointed weight, depending on what their initial baseline body weight was. And after 48 weeks of treatment with these medications, only 47% of them did not even achieve their disappointed weight. So they didn't even get to the lowest tier of all those weights that they identified, which is very disappointing for a lot of people. So the U.S. Preventative Services Task Force actually put out a statement that says that patients should be told that these medications are going to, at best, lead to a modest weight loss. So nothing more than that. So patients are understanding what could potentially come from this. And as far as research concerns, most of the papers that I looked at, the more recent ones actually discuss this, that most of the studies that the numbers come from actually have a very significant attrition out of the studies, lots of people dropping out. A lot of the studies employed run-in periods where patients are actually kind of selected out because they look at their behaviors, whether or not they are going to be compliant, and if they're potentially a non-responder, and then take them out of the study before even running the trial. And I know my personal patients are often very non-compliant and not very good patients sometimes, and so they wouldn't even be included in this data series. And then down at the bottom you can see, go back. So the last observation carried forward is often used as well, where if a patient drops out of the study, the last data point is used. And so with this, it's kind of opposite of this, this table here, this chart here, that you're seeing with the last data point that they continue on and maybe would have lost more weight, or maybe they would have gained more weight, but that potentially there could have been a difference, but we're seeing them as if they never left the study. So there actually is a law which covers all controlled substances called the Utah Controlled Substances Act, and it covers these medications, which I wasn't aware of, that there was actually a specific section on this prior to starting this research. And it is a Schedule IV controlled substance and is recommended for the treatment of excessive weight with increased health risks. And they recommend it only in combination with comprehensive weight loss programs, so that includes nutrition counseling, pretty thorough evaluations. We'll talk a little bit more about that. So the evaluations is very important, and that the patient has made a substantial good faith effort to actually lose weight prior to being started on these medications, not that they have never even tried, and this is the easy way to go. That the benefits of the medication outweighs the possible risk, side effects, that they don't have comorbidities related to their obesity that would put them at risk with taking these medications. And they even recommend doing an informed consent and letting the patients know that we don't actually know a lot of the long-term outcomes of these medications, so that they're aware of that before starting treatment. They require close supervision and monitoring, seeing these patients frequently. If you're giving them medications, you should be overseeing it very closely. And that they're making ongoing progress towards their goal weight or maintaining their weight is one of the most crucial things, and we'll look at some data locally about that. And more importantly, if the medication isn't actually working, to take them off of it, because there's no benefit and just risk to the patient if they're continued on it without any additional weight loss or maintenance of their weight. So looking at, this is the kind of general consensus regarding recommended practice and how to go about prescribing these medications and when to stop them. So initially in the first month of treatment, we would want to see a 2 kilogram weight loss, or 1 pound a week for the first month. And if they're able to achieve that in that first month, then the medication can be continued. And after that, the goal is to reach a 5% weight loss by 3 months of treatment. And this changes a little bit with the phentermine Topamax combos, which we'll talk about in a moment. And after that 3 months, we want to see that weight has actually been below 5%, remains below 5% to be continued on the medication for maintenance. So to talk about phentermine a little bit, it is commonly the most prescribed medication for appetite suppression in the United States. It was approved in 1959 for the short-term treatment of obesity. It is not approved for long-term treatment outside of 12 weeks, according to the FDA. And the concerns around this, a lot of the bad side effects from fen-phen came from the fenfluramine portion of that. But phentermine is not without risk because it is a stimulant. There's also potentially risks for tolerance and dependence on the medication because of that. although that's much more rare. The studies, looking through 5 or 6 different studies and large studies that they did, actually showed a pretty significant weight loss, so getting below that 5%, even up to 15% weight loss. But many of these studies had a very significant calorie restriction, even down to 900 or 1,000 calories per day. So in combination with the medication, we're also cutting the calories back quite a bit, and surprise, surprise, they lose weight. Most of the weight loss that they see happens within that first 6 months, and then after that point, less so. Topamax was approved by the FDA in 1996 for seizures and then migraine prophylaxis in 2004 with a side effect of weight loss, but it was studied in monotherapy and found to have too bad of a side effect profile if it was used in the dosages that they would have to use to obtain the adequate weight loss. It does work in a couple different ways. It mediates appetite suppression and leads to satiety and also even changes the taste of food, but it also works independently from the weight loss on some metabolic factors, including insulin action, skeletal muscle, glucose transport. So it actually has an interesting action that's totally separate from the actual weight loss and appetite suppression. So the most recent of well, not the most recent, there's actually a newer one since this, but Qsymia is one of the more commonly recently prescribed medications. And it came out in July 2012, was approved by the FDA for long-term treatment. And currently, Qsymia, or this combination of topiramate and phentermine, is the only long-term treatment outside of orlistat that's approved by the FDA outside of 12 weeks. It allows for lower doses of either of the medications, so there's fewer side effects that come from either of them because of the lower doses. There's an improved weight maintenance outside of that initial treatment period where phentermine would be more appropriate, that they can actually maintain their weight. And then they often have improved lipid and glycemic index profiles and sleep apnea with the weight loss too. Ideally, it's best used in obese men and postmenopausal women. It does have some teratogenic effects, both of them. Phentermine and topiramate both are category D for topiramate and category X in pregnancy. And not used in patients with hypertension or coronary artery disease, so making sure to filter out those patients. The goals are still the same, 5% weight loss, but you want them to be on the highest dose before you consider it a failure, but they still have to meet those initial criteria of the 2 kilogram weight loss to be continued on it, or they're considered a non-responder. The patients typically lose weight up to 1 year and then maintain that weight better after 1 year, but after that point, they're less effective at continued weight loss. Because it's new, there's not as much data on the cardiovascular safety, and so that's something to keep in mind in making sure that you're choosing the right patients for these medications. The price for Qsymia, obviously, with it being new, is much, much, much higher than the 2 medications separately. Topiramate and phentermine separately are $10 each for a 1 month supply, and then Qsymia is a few $100s. So looking at the data really quickly, I looked at some data from 99 prescribers in the urban north region, so this region that we practice in, and came up eventually with 1,764 individuals that were prescribed these medications, either phentermine or the combination. And so these are the regions for those of you not familiar with this area that we looked at. So as far as prescribing practices, you can see that the majority of patients that were prescribed these medications were prescribed by a male provider. And even correcting this with the amount of female providers within that 99 versus male, it's still 2 to 1. Oh, keep doing that. Still 2 to 1, so 19 per female provider and 40 per male provider. Pretty equal amount as far as the duration of prescriptions. That doesn't necessarily mean that they're getting prescriptions every single month, but that was the first to the last prescription. And then the age groups, the younger age group tended to have a shorter duration of treatment, and then the middle age group from 41 to 56 actually had the majority of the prescriptions. So the most interesting thing with getting this data is that not all of the data points or the phentermine prescriptions that were prescribed were associated with a weight during their visit. And I was very skeptical of this, so I actually started going through some of these visits, and there's maybe partial vitals, but no weight associated with giving them the prescription. And with the data mining that we did, it actually looked for an average of anything anywhere else within the system within 30 days before the prescription was given. So even if it wasn't done at that visit, just looking for something. And often that was not the case, and the initial 10%. And then another 30% had one weight on the first prescription, but no follow-up weights. So initially had over 3,000 data points, or patients initially, and then came down to 1,700 that actually had both data points. So looking at this chart, this is goes by duration of treatment. So starting with those who received 1 month of treatment up to 32. And it actually went a little bit further than that, but some of the data later on was not very good. Half of the prescriptions are prescribed to individuals for treatment of 9 months or less, and then the other half are for 9 months or greater. So not necessarily sticking with, and 99% of these are phentermine prescriptions. It's unknown whether they're with a separate Topamax prescription. And then looking at average weight change, if we're looking for the 5% weight loss to be considered effective, the first time that we reached that on average with these patient groups who received these durations of treatment is at 17 months of treatment. And so up until that point, the average weight loss ranges for some of the best, almost 2% or a little bit over 2%. But some of them actually have an average weight gain for 15 months of treatment, that they're actually gaining weight during that whole time, or potentially going down and then back up and above their baseline. So we talked about that a little bit, and potentially some of the bigger numbers later on are because we're filtering out some of the non-responders in that early group, I hope. 44% of the individuals that were in the study actually gained weight during their treatment, and then 31% did achieve that 5% weight loss and maintained it throughout the treatment period. So how do we measure up? With weight gain, we averaged a 7% weight gain of those who gained weight, and with weight loss, we averaged 7%, or a little bit, almost 8% on both, weight loss of those who actually lost weight, and overall, all of the patients combined, we gained 0.03%. Looking at follow-up, this is one of the biggest concerns with phentermine, is that after the medication is stopped, potentially patients will regain the weight, and you see this happening here. So in that first month, there was a little bit of positive weight gain, and then by the second month, you do see some potential continuing of the effect of the medication or maybe the interventions that they started. And then by 6 months out, we're back to where we started with an average almost null, almost equal to where we started at our baseline, a little bit weight loss at 0.13%. So the major difference between the studies and real life here is that some of our patients don't take them as prescribed. There's a lot of prescriptions that the patient follows up 3 months later, and it was a 1 month prescription, so potentially not taking it every day. But mainly with the patients that I've seen is just the lack of control over dietary and exercise, some of those interventions, and the fact that we're not necessarily talking to our patients as much as we should about those things. So just the last point here is that there are some options for outpatient health coaching that is actually not very time consuming, and we can use a lot of the care guides and care managers, a lot of this patient-centered medical home stuff that's starting to be implemented to help us out with this. One of the proposed models included 3 office visits and then 7 phone-based virtual visits to kind of coach patients through some of the health barriers that they reach that kind of keep them from losing weight or keep them from doing these things. And the models that were most successful integrated goal setting, they integrated barrier identification, feedback for these patients, and really close monitoring so that patients know what's going on. You're helping them kind of get through some of the struggles of this. And they looked at in-person versus remote information as far as talking over the phone about this education, and it didn't make a difference for this type of conversation. So having that conversation over the phone is as effective. So in summary, one of the main points is that phentermine is not approved by the FDA for long-term treatment of obesity. Currently, Qsymia, or these 2 medications separately, or orlistat, are approved. And there is some pretty good data behind Qsymia, or that combination, for weight maintenance if you're going to start a patient on this type of medication. The benefit should always outweigh the risk of the medication, making sure that you're really doing a thorough workup of the patient before starting them. And then following them closely, making sure that they have weights when you're giving them a weight loss medication is really crucial. I think of it as like diabetes, that we would not get an A1C before we started insulin on a patient because it could be detrimental to the patient. So we want to make sure that we follow that closely. And then potentially implementing some of these models that are coming out within the last couple of years to use in our own clinics to help educate our patients about what they can do to help with weight loss. So that's all I have. Thank you.
So I'd like to invite the resident physicians to come up to the table here, and for those of you that have questions, you can make use of the microphones along the sides and in the back for any specific topics you have to further thoughts on. So.
Is it on? I'm Ralph Frizz. I have a question for John Gardner. A couple of them, actually. Are you going to run in the marathon tomorrow?
I'll be running a leg of the marathon. I'll do the relay.
And the next question is, do you have any statistics on incidents of rhabdofollowing marathons?
You know, there's actually is I don't have the exact numbers, but there is definitely incidence in that. You know, if you were to check the CK level of marathon runners across the board, you know, they're going to have increased levels. Some of the studies have quoted about a level about 4,000 from what they've checked, but usually that recovers pretty fine afterwards, and so most of those are not admitted. For the ones that are admitted to the hospital are ones that do not follow the typical course and have worsening symptoms. And so it is common.
Question for Natalie. So a patient is on hospice, and the patient or the family decides to take them to the ER because, you know, they have pneumonia or something. And my understanding is the hospice benefits terminate at that point. They get admitted to the hospital, they get treated for the pneumonia. What's the chance of them going back on hospice at that point once they get out of the hospital?
So you're you're right. If they want to go into the hospital and seek curative therapy for any reason, then they don't qualify for hospice at that point. Going back on hospice depends on the scenario. Sometimes hospices won't take them if they're continually non-compliant or difficult to keep on. But if they still qualify and they're wanting to go back on hospice, then they'll usually take them. I would say the majority of them can go right back on. But it depends. I mean, it depends on why they're going in and all of a sudden seeking curative therapy, because that's not really the goal of hospice care.
My question is for Dr. Gardner again. So I'm a practicing rheumatologist in the area and use quite a bit of allopurinol, and wanted to see if you could clarify the use of allopurinol for the rhabdomyolysis. You mentioned that it could be used potentially as a therapy, and there are very specific indications for its use. So I wonder if there are any new recommendations for its use in rhabdomyolysis.
So their recommendations, from what I could find from the literature, was above a certain level of uric acid level. So I believe it was 8 is what the suggestion was. And it's not a long-term thing that you need to do. It's just until you get back to a normal range.
So is it just treating the hyperuricemia then, or are we worried about gout or?
Not really worried about gout, although there have been some gouty flares that have been documented, but it's mainly treated at the hyperuricemia.
I would just add something that, as I understand, the FDA approval for allopurinol is for hyperuricemia in chemotherapy management, not in any other situations. I'd invite any other comments.
This question, comments directed to Dr. Brennan. Relative to this idea that we continue to get surveyed over and over, and I've noticed within our office, we're an HCA facility, and our numbers are posted, and it's always amazing to me that something such as the status of the parking can vary from provider to provider. You know, clearly there's a lot of bias that goes into when people complete these surveys, and as physicians we're increasingly scrutinized, and yet your data suggests that if anything it may even promote less, a lower quality of practice. At what point do you think as physicians we need to say, wait a minute, we shouldn't be surveyed in this way? This is actually doing a disservice, and to tie reimbursement to this is even more of a problem.
Excuse me. Definitely it's interesting when you look at patient satisfaction surveys. This is just one aspect of what we're looking at. There's been studies that look at, do patient satisfaction surveys correlate to outcomes? And those have been good and bad. I think the data is still out, and we need to more studies have to be done to better evaluate this.
I have a question for Dr. Sperry, actually a couple of questions. The first one is you told us that there were some requirements. You had to have specific training to evaluate concussion in a and an athlete during the last 3 years. Can you tell us is that a structured type of training that has a certificate or something like that that's required? And then my second question has to do with late presentation. So I sometimes get patients that have come in, have had a concussion a month ago, are claiming to be asymptomatic, but they've also got pressure from their team to return to play, and they're saying that they need a note to return. Is lack of symptoms at that point sufficient to send them back to play, or do they still need to go see the neuropsychologist or things like that?
So for the first question, as far as I know, Utah does not specify exactly how that is. The training's supposed to be done if you took a CME course, if you went to some particular training, because there's a lot of hype about this recently. If you just document that you've had that training, that's sufficient. And if you're a qualified provider, such as an athletic trainer or a physician. For the second question, it kind of depends on, because we talked with our neuropsychologists in developing this algorithm, and they are very well versed with doing those 504 plans and figuring out what to do for a student who needs to have that help. I would say if they are symptom-free and if they pass just a basic test, like the computerized tests or the SCAT, then they are able to go on to have that graded return to play and graded going back to school. If at any point during that they still have symptoms, then they would back off. But in talking with some of the neuropsychologists we developed this with, some of them said, it would be ideal if every single person with a concussion could see them, just to make sure that things are not missed, but it's not really viable. And so they said really only after a month of symptoms, and it didn't resolve, that they would want that referral.
This is a hospice question. In what way, if any, is a full-time nursing staff and their authority and jurisdiction with the patient influenced positively or negatively by also having hospice come into for a patient that is whose residence is the nursing home? The reason I asked the question is because I recently talked with a family that bitterly complained about making requests of the full-time hospital staff and for this, that, and the other, and being continually told that they couldn't do anything about it because that part of the patient was under the jurisdiction of the hospice program that was just there on a very limited basis. Is that something that you see, and if so, is that a potential problem?
So to clarify your question, you're talking about in a skilled nursing facility?
Yes.
So a patient who's on respite stay in the
Yes.
skilled nursing facility?
Yes.
And then they don't qualify to stay longer? Is that
Well,
what you're asking?
it was a terminal cancer patient with a short, obviously, life expectancy.
Mm-hmm. So the nurses in the nursing home were saying they couldn't care as much for the patient? Is that
Yes,
what you're
and
saying?
that's secondhand. This is just relayed through the patient or the patient's family, but they had high hopes for hospice being a help, and they really were. But there was also that attendant problem of the nursing home staff deferring and saying they couldn't do what the family wanted them to do because that was under the control of hospice.
So nursing homes and hospice can be complicated because they aren't always the same team, and hopefully they play like a team and really work together. Hospice doesn't cover nursing home care, so like I mentioned earlier, you have to be in a nursing home for, you're financially paying for it. And if you're in for rehab, like a short-term thing, like a hospital discharge, and you have your 30-day window, you do not qualify for hospice during that window because Medicare's not going to pay for rehab and hospice care. So there's a lot of issues with payment and hospice. But once someone does get in a long-term skilled nursing facility, either because they're paying for it or they've gone on to Medicaid and they're on hospice, ideally those two teams will work together. But the primary physician is generally the hospice team, and they do generally make the rules. So if a family was really concerned that they weren't being listened to, I guess the best thing would be to go through the hospice nurses and say, we aren't happy with this. And a lot of times patients in nursing homes don't get a lot of benefit out of the hospice care because they have full-time support, they have a nurse there all the time, they have good pain control, and so a lot of it's just those spiritual needs, and a lot of times they really don't benefit. So maybe in that case, the best thing would be to come off hospice. It's not gonna change where they live, and it's not gonna change their prognosis. It may just change some of those barriers that they're worried about.
Question for Dr. Flanagan. So sinusitis and bronchitis. So it seems there's a time qualifier for sinusitis. You know, if a person is past 10 days and they have sinus pressure, headache, facial pain, teeth pain, ongoing illness, you know, most at that point would give antibiotics. But what about the persistent bronchitis cough? Any of us in primary care see tons of persistent coughs, 2 to 3 weeks of coughing, and they have bronchitis, and they're in the Instacare. Is there really any evidence that says giving an antibiotic for persistent cough is indicated if it's a bronchitis cough? And even in the case of pertussis, I'm not sure there's a lot of great evidence that says treating pertussis at that stage of the game is going to terminate their cough.
Yeah, those are good questions because that's what we run into a lot in the urgent care setting, clinic settings. Well, geez, doc, I've been coughing for 2 weeks. I need an antibiotic. Clearly the mics don't like me. Pertussis, from everything that I've gathered, is that we treat it not necessarily because it's going to make the patient better, but it's going to reduce their risk of reduce their risk of passing it on to other folks. But once you get it, you're kind of still stuck with it. Now, I could be wrong on that, but that's what I've heard. Again, I haven't been in practice long enough to see enough pertussis cases to say, oh yeah, you know, we're going to treat you, you're going to get better quicker. But rather, it's more you're still going to have the cough for weeks and weeks and weeks. But that's related specifically to having, you know, a documented case of pertussis in terms of just cough in general. If we rule out flu, if we rule out pertussis, we rule out pneumonia. Yeah, you can have a post-infectious cough lasting for weeks to months. And, you know, the little care process model that I was referring to didn't really touch on, well, what if you have a cough for 6 weeks? What if you have it for 8 weeks? I think that's the point where, you know, clinical judgment plays in. But again, what are you treating? I mean, are we still just treating a virus? Are we treating just a post-infectious cough? Are we treating an allergy?
I have a question for Dr. Brennan. So with all the research and the literature reviewing you did, I mean, your research showed kind of differences between those who were prescribed opiates or antibiotics and those not. Is there any other confounding factors that may be involved? Did you see any relationship to age or gender or any other anything else that might help us predict which patients are more likely to give you a top box score versus not?
Looking at all this, it's very complicated. You have to deal with human nature, and that's not always easy to put it into a box. In terms of age, we didn't get a chance to look at that. Definitely more studies should be done. We did look at the difference between patients who are in the outpatient setting versus the Instacare setting. And when you look at the antibiotic data for the outpatient setting, it wasn't statistically significant. However, when you look at the Instacare setting, there's I think a 6% difference between those who had what we call a viral infection and received an antibiotic versus those who didn't. So that would suggest that that your relationship with your physician did increase your top box score, if that makes sense. But definitely there are a lot of things that we weren't able to look at. Something you can do next year.
My question's for you, Cassie. So I've been shocked with how large a burden phentermine has become in my practice after residency. And I have been surprised that the few people I've had the most success with are women in their late 30s who aren't obese, but they're overweight, and they're significantly over their goal weight or their ideal weight. They're active, they're healthy. One was postpartum, about a year postpartum. And after months of lifestyle modifications, they've twisted my arm, and finally I've said, fine, we'll do 2 or 3 months of phentermine, and they've had great success and then have kept it off.
Right.
So I'm just wondering if in your research you came across anything about that category of patients, women that are overweight, not obese, highly motivated.
Yeah, I didn't see anything specifically, but definitely it's kind of almost like you did a run-in period for those patients, because you're looking at whether or not they'll be compliant with the medication. And so for the same reason that we look at the research and don't consider it as that the results may be a little bit skewed, you did with your own patient in filtering out the patients who may respond better by making sure that they're going through all of those exercise and dietary interventions, lifestyle modification before starting the medication. That's likely why it was more successful, and that's what a lot of the papers showed. And you're using it appropriately within the 3-month time frame, so that's great. But not anything specifically as far as like the age range, but a lot of, they tend to try to avoid using it in patients who are premenopausal because of the potential risk, the birth defect risk. And with using it like you're using it, the main thing to focus on is making sure that you're checking pregnancy tests really frequently to make sure that they don't persist on it while pregnant. But it sounds really good. So there wasn't anything specific that I saw.
So I also have a question for Dr. Whittier. So given the challenges that you've come up with medication use for obesity, what is your personal approach going to be as you have that obese patient that really has done all the requirements beforehand, it's been unsuccessful, and if you put them on a combination medication as you've described, how long are you willing to keep them on it?
I think looking at that chart where if they are able to lose the initial weight, then continuing them on it, and then if they're able to get below their 5%, potentially outside of a year, they do show better maintenance, not any further weight loss, but potentially as long as it's effective. If they start to regain the weight, then you'd want to take them off of the medication because the benefit is outweighing the risk, or the risk is outweighing the benefit at that point. But I personally kind of trying to come up with my own patterns, and that's where a lot of the questions came regarding this, is asking some of my colleagues and advisors, what do you do? And a lot of people are like, oh, absolutely not, or I do it all the time. And so he actually asked me to talk about what I would actually do after this study, or after the studies that we did. And I think that I still would be willing to do what Dr. Drollinger has been doing as far as the short time frame of phentermine in the right population, in a population that it's going to be effective in, or potentially the combination, either if their insurance will pay for it, the combination or the medication separately in the right population as well, and patients that don't have a contraindication to it if they've gone through, made that good faith effort beforehand. So.
Okay. On Dr. Whittier, again, I just have a question for you regarding the other type of medications such as metformin or the Viatas and such. Can you use them with these medications, or has that not been studied? And the other question is, they all have comorbidities when you, code them, but I'm just wondering, how do you get it covered through the insurance when you see them on a near monthly basis for counseling and such? Is that a problem with most insurances, which I found some are okay with it, some aren't?
So the a couple of the papers that I looked at actually did show a lot of the studies regarding other forms of weight or medications that are used for weight loss, Viata, metformin, even thyroid hormone, kind of looked at some of the data. I didn't see anything specifically where they were combining the patients with those issues with the phentermine or the combination, and potentially because of the potential contraindications in those populations that are on, diabetes is one thing, but if they have other coronary artery disease or other things, then potentially that was the reason. But I didn't see anything combining that. And then as far as insurance covering it, I actually asked the pharmacy at our hospital, and I didn't go into when it would actually be covered, but the cost, a couple $100, is actually coming from a KD, and they said, that's why they said going to the medications separately. And for the visits, actually seeing them frequently, as far as I know, and I'm not very knowledgeable about it, but that if you're seeing them monthly to prescribe a controlled substance, it should be covered by their insurance because you're following this medication that is supposed to be followed that closely, but I don't know the exact details on that, so sorry.
It's past noon and our other conference is starting, so why don't we, if you have individual questions, come up, give them a good round of applause.